anesthetic, they clean and deep so that she isn't watching what's going on. Skin incision, uterine incision, they'll break the amniotic sac if it's not broken yet. They will remove the baby, whichever part is there first. Nutrients now have the window, so when it's actually time for the baby to come out, they can drop open it up so the mom can see the baby born, and then cover it up so she's not watching the whole surgery. Some too that have arm holes to hold blood, so the mom can reach in and lift her baby up, like she were vaginal delivery. It tends to incision and uterus incision. The most important one is the incision on the uterus. Okay, they may make that transverse incision on the skin, and then they have difficulty getting the baby out to make further cuts on the actual uterus. The allows for more room if the baby's very big. Horizontal, and most incisions are. I'm going to, before we watch the video, I'm going to take the slide so you can see. So low transverse incision, also kind of sometimes referred to as the bikini incision. This is what's most common for a C-section. Okay, they'll make that very low transverse incision. This is the only one that allows a mom to potentially have a vaginal delivery in a future pregnancy. Okay, there's not as many muscle fibers in the lower part of the uterus. Remember, that's more of a passive section that allows for some stretching so that the baby can be delivered. So not as many muscle fibers. The concern is that with a future pregnancy and all the contracting that can occur, those muscle fibers can cause the uterus to rupture. So less muscle fibers in the lower part, which makes this the only one possible to have a vaginal delivery in the future. Anything vertical is a big no. Too high of a chance that the force of contractions will cause that incision to break open. Okay. So watch this. Sometimes they make this incision, and if they're having a hard time getting the baby, they'll go up still and make an upside down T. So that's why it's important to have it documented what the uterine incision is, because that's what's going to determine future births. Yep.
Yeah, they let my mom do that. So with me, she had the one on the right, but I don't know if they did that cut on her uterus. That's the cut that's on the outside. I don't know if that's the cut that's on her uterus.
Right.
Because my sister after me, who was born 7 years later, she was vaginal. But my siblings after that.
Yeah. So it's not so much what's on the outside as what's on the inside. They usually match, but not always. So that's why it's important to, if you switch, if you have the same provider, your provider's going to know what, they're going to have your chart, but if you switch providers, make sure there's all that information goes with you. But it's for Northwestern Medical Center. And this mom is going on. So there's a way to deliver her early because she has something called placenta accreta, which we'll learn about in this chapter. But with placenta accreta, the placenta goes kind of in which when it's time for it to run. So we'll go back for it.
And because she said that surgery, she's not a candidate for herself. She's not a candidate for herself. Has a diagnosis of placenta accreta, which means that the placenta is growing. Hysterectomy, and that's where we include my partner, Dr. Roque, the oncologist. The oncology surgeons are the pelvic surgeon experts. And we know that that placenta, although it's not a malignancy, it sometimes behaves like. So about 30% of women will undergo cesarean deliveries. So it's a very common procedure. But let's not confuse common with easy. We know that in having a cesarean delivery, we were more risk than with the vaginal delivery. And one of the risk factors of having placenta accreta is having a prior C-section. That's what the uterus should look like all the way on the exterior of the uterus, but then this area here is the incision on the uterus would be at the bottom because that's all covered by placenta.
Oh my God.
Bringing a little bit.
This is
Baby, breathe.
Oh.
There we go. And we're gonna let mom and dad meet their new baby. Look, guys. Beautiful. Hi, cutie. Normally, once baby delivers, the placenta detaches. But because the placenta is growing into the wall of the uterus, it doesn't detach. And in fact, we don't want it to, because that would increase blood loss for mom. So we'll very quickly close this uterus so we can proceed with hysterectomy. We know that during pregnancy, the blood supply to the uterus has increased to an extent that you can lose a liter of blood in a minute. The blood vessels that are feeding the uterus, feeding the baby, are huge. And so that makes the hysterectomy all the more difficult and totally different than a routine garden variety hysterectomy. The general OB-GYN really wanted to do their career. I think the last month we've had 4. And the reason why it's important to come up with our question is we have the team here. We have the team that just with each other, blood bank that can provide all the products that we need to ensure that we keep our patients safe. We have the nursing team who's used to taking care of patients in this type of situation. The team that takes care of women with these type of complex problems is so very rewarding. And it's one of the major reasons that a lot of us went into OB, to keep moms and babies safe. As you can see, this is the uterus. This is where baby lives. The placenta is inside. This is the incision that we made to remove baby. The fibroid, we talked about the fact this patient had multiple fibroids removed in the past. She still has some there. So there are so many things that went into making sure that today was such a successful day. Things like give mom steroids, baby's lung would be more mature, understanding that baby would be delivered a little bit early. We checked mom's blood count to make sure that her blood levels would be high enough that she could do well during the surgery. And we made so many plans in terms of when and what doctors were going to be here for the day. So we were able to put everything together, and we get a healthy mom, healthy baby. So thanks for joining us in the OR to see this magical day.
So, as I said before, the mom had something called placenta accreta, which we'll talk about in this chapter, but the placenta is growing into the wall of the uterus. Once the baby's born, the uterus continues to contract, and the placenta should separate nice and cleanly from the wall of the uterus. But when it's growing into the wall, it doesn't do that. So in that scenario, that mom must have opted to hysterectomy afterwards. So rather than trying to deliver the placenta, they deliver the baby, sewed it back up, and just put the whole uterus out with the placenta as well. Okay. Trying to remove the placenta will cause a lot of hemorrhage, a lot of bleeding to occur. They elect to do these early for a few reasons. They don't want her to go into labor, just with having the previous scars from the fibroids as well. And also to have the right team there, right? You don't want, when you have a placenta accreta, you want to do that in a controlled environment, which usually is during the day with they had an OB, GYN oncologist there. Because, as she mentioned, the placenta is not a malignancy, but it acts like one, as in the placental tissue kind of rapidly grows. So they had them there. They usually, sometimes we'll have like a trauma surgeon. They want to do it in a controlled environment and not at 3 a.m. when he decides to go into labor. Okay? And they would have finished this round. So that was that one. Huh? Okay, so in the recovery room, vital signs are done. We want to make sure mom's not hemorrhaging. IV site is monitored. We'll check the fundus for firmness on the umbilicus and make sure it's midline. Dressing for drainage. Lochia will look at quantity, color, presence, class, just like we would for vaginal delivery. We'll look more into the descent of the fundus and also lochia in chapter 9. Creating urine output from the catheter. We got to make sure I keep that bladder empty. Okay. All right. So now we're going to go into abnormal birth, hypotonic and hypertonic labors, also called dysfunctional labor. It's a terrible term. Like failure to descend, failure to progress, like failure, if there's anything they can do about it. But a dysfunctional labor is when there's not normal progression of labor. Okay, if you're having adequate contractions, you should have the cervix to continue to dilate, and you face, and the baby to continue to descend. So a dysfunctional labor does not progress. There's an abnormality in one of our 4 Ps. Right, and our 4 Ps of labor are powers, actors, passenger, psyche. Those are our 4 main Ps. So we may need to use some intervention. Factors for functional include advanced maternal age, extension of the uterus, abnormal presentation. We have a baby that's too big for mom's pelvis, maternal fatigue, dehydration, or fear, and a lack of analgesic assistance. There are 2 types of dysfunctional labor, hypertonic and hypotonic. So hypertonic labor usually means the uterus has increased muscle tone. Also sometimes an irritable uterus that has always contracted. Usually occurs during the latent phase of labor, so very early on. Contractions are and really coordinated. They're painful but not productive. Uterus is kind of tense in between contractions, so they don't do actually dilate and face the cervix. Hypotonic labor has decreased uterine muscle tone. Okay, so labor starts off good, contracting, dilating, and facing it, and then all of a sudden things slow down. Okay, we're not getting progress. And this is during the active phase of labor, so, halfway through, roughly flushing. This is more likely to occur if the uterus is over-distended. Remember, the uterus is a muscle, and it can get tired. So very long labors can make the muscle tired. If there's one baby in there and everything kind of stretched to its max, it can make the muscles tired. And when it doesn't want to contract anymore, it's not going to contract. It's just like if you're weights and you to that point where you're like, can't lift it up anymore. Right? The muscle is tired and can't do the work. So the same thing can happen to the uterus. Okay, so what can we do to help augment a labor that is stalled? We talked about it yesterday.
Nipple stimulation, sexual intercourse.
Well, during labor, yes. Not in the hospital. Before you break the water, right? If your amniotic sac's not ruptured, then you can rupture the amniotic sac.
So I'm sitting here debating.
Problems with the hours of labor. Ineffective maternal pushing. The mom may not understand what technique to use, or they're scared to push too hard. They're afraid they're going to tear, so it kind of pulls back on the pushing. If they have an epidural or a subarachnoid block, they may not feel the urge to push. can affect how well they push. Sometimes they need to feel that perineal pressure. You know where to push, where to exert the energy. If they're exhausted, they may not have the energy to push. They're too tired. So we use our interventions for the stage of labor, like forceps and a vacuum, to help deliver the baby if mom's getting too tired or is not pushing effectively. Problems with the baby. The passenger might cause the labor's progression to be dysfunctional. These problems include size, presentation, or positioning. So a baby that's breech, a baby that is occiput posterior, so that's facing up, is going to be a problem, or if they're a face presentation. Right. Other factors might be if there's more than one baby in there, or birth defects that may make delivery more complicated. Such as like hydrocephalus. Hydrocephalus is extra fluid around the baby's head. It causes the baby's head to be very large. Okay, so even though the baby may be a normal size, if their head is very large, that's the part that's got to fit through first, right? And it may result in a dysfunctional labor. Birth canal, and these guys can contribute. The problem is the baby gets bigger. Stuff usually hung up on the pubic. And an emergency, the head is out. You can't breathe, can't do anything, kind of cut off oxygen supply. Maybe out quickly. And it's, or often results in a fractured clavicle for the baby.
Isn't there sometimes the mom's, is it her coccyx or something at the end?
It can break the coccyx bone on the mom, but likely to have a fractured clavicle. Laceration for sure, if the baby's not fitting. The fractured clavicle, believe it or not, you don't have to do anything for it. It heals on its own. Yep, pretty quickly. Their bones aren't fully calcified, so we just swaddling them is all that you need to do. But we do make note if they're not using an arm or lifting an arm. But it is an emergency, and at that point, the baby's got to come out that way. You can't put them back in. So it's break the clavicle, or the alternative is not desired. Abnormal presentation or position of the baby. This prevents the smallest diameter of the baby set to pass through the smallest diameter of the pelvis. So ideally the baby will be occiput anterior, okay, facing mom's back. That allows for that occipital part of the baby's head where that posterior fontanelle is, and all those bones to kind of mold into that nice cone shape so that they can fit through the birth canal. Okay, they're nice and tucked. Nice and flexed, cephalic, and occiput anterior. If the baby's in an abnormal presentation, it's not going to pass through easily. It interferes with the most efficient mechanism of labor. It can cause a cord compression and may require an external version. Baby who's in an abnormal position, common cause is that the baby is occiput posterior or face up. That can lead to a very long labor, longer dilation, longer pushing stage, lots of back labor that can radiate down the legs. Right? They may need. They have classes now. I think all the nurses took it at where I work per diem, called like turning babies or flipping babies, and it's learning different positions that you can put moms in when they're in labor to help get a baby into the optimal position for delivery. Okay. So this just illustrates the steps of a breech delivery. It is not ideal to have a baby a vaginal breech delivery.
Actually, I've seen one on Facebook a couple days ago.
You saw one on Facebook a couple days?
I follow a birthing page.
Okay. Here's the concern. What happens when we get to this part, one of these parts here? What is sticking down here?
The umbilical cord.
Umbilical cord that is attached still to the placenta, right? And it's gonna be feeding the baby oxygen and nutrients and all that stuff. But when we get down here, or over here, there's no room for that cord, that head. The head is hard, and it's gonna completely occlude flow from the placenta to through the umbilical cord. So the baby's oxygen supplies are gonna be cut off. Their head is also not entering first, so it's not getting that nice cone shape. So their head's gonna be bigger, kind of, it's gonna be round, completely round. So they're concerned the head's gonna get stuck. And that's why, you know, it's not ideal to do elective vaginal breech delivery. Now, sometimes they come in and they're halfway out and you just gotta roll with it. If it's a home birth, as you said, it's a home birth, yeah, a lot of times they'll do it. It's risky, you gotta be aware of the risk.
Yeah. It looked like from the surroundings, like if they were in another country. Like judging by like the cloths and things, the patterns on the ground and stuff like
Yeah.
that, it looks like they were like somewhere.
If it's the second baby in a breech delivery, in a twin delivery, sometimes they will, just because the first one kind of paved the way, so to speak, made some room
Right.
for the second one. And in general as well, twins are usually smaller. So the concern is not there that it's gonna be a 9-pound baby. So. Abnormal positions. You want to encourage a woman to assume positions that favor fetal rotation and descent. Have her move around. Use a birthing ball. They like, you know, leaning over, like squatting, sideline, doing lunges. Who wants to do lunges when they're in labor? But you can do lunges. Really, just changing positions is going to help that baby descend through the birth canal. So here's another image here of an occiput anterior baby versus occiput posterior. And I like this, shows the best, right? If you imagine that posterior fontanelle is right around here, and all those skull bones are able to fuse into a cone head for delivery. That can't really happen if the baby is face up, if the baby's facing out, or occiput posterior. And so lots of back labor, longer pushing stage when a baby's face up. Okay, if there's more than one baby in there stretches that uterus to the max. Again, it gets tired from over-distension. If there can be abnormal presentation or position of one or both babies. Sometimes one baby's delivered head first and the other one may be breech. Section. So we'll get the best for one shot. But that's a risk that moms want to do a vaginal delivery with twins. Just because they're both head down, they're both going to stay that way. First, like, look at all this room. Start doing like somersaults in there. So it's a 10. Yeah, you know. Yes. So if there's more than 2 babies, it's a C-section. You got to monitor the babies separately. Okay, there's going to be a team for mom and a team for each baby. So it gets a little crowded in there when there's more than one baby because you have to have somebody there for each baby. Problems with the pelvis and soft tissue. We have smaller shaped pelvis that can affect the ability of the baby to be born vaginally. And our ideal pelvis, soft tissue obstructions can occur. Most common is a full bladder. I gotta make sure that bladder is empty. Yeah. of labor as well. You can have an abnormal duration of labor. Now, these are just kind of guidelines. This is not, everybody's labor is going to be a little bit different. Well, some people are in labor a very short amount of time, some people are in labor for days. There's women that have what's called prodromal labor, where it's just these constant irregular contractions that are, you know, they may last for an hour and then they stop altogether. And then they come back. It's very tedious and wearing on the mom, tiring. But once there's active labor and regular contractions, you know, things should progress. But once there's active labor and regular contractions, you know, things should progress according to this Friedman curve. Prolonged labor can cause infection in mom or baby, especially if the amniotic sac is ruptured. It can cause maternal exhaustion. It can cause increased risk for hemorrhage and anxiety and fear. So here is our Friedman curve. So this darker blue line is for experienced moms or moms who are not having their first baby. Okay, so you can see they jump up much faster. It takes them a much shorter amount of time to go from 6 to 10 centimeters and deliver. The whole thing's usually within, what's that, 8 hours-ish, where if it's a first-time mom, it could be 14 plus. Okay. Just kind of drags out a little bit more. But again, this is just a guide. Okay, everybody's going to be a little bit different. All right, we'll do precipitous. We'll do a couple more slides here. So precipitous delivery, I think I mentioned this word yesterday. In less than 3 hours. That sounds wonderful. Labor begins abruptly and intensifies quickly. You go from 0 to 60 very fast. Contractions may be frequent and intense. Often from the start, there's no easing into it, no building up on these contractions. They are fast and furious from the get-go. Can increase the risk for uterine rupture, cervical lacerations, or a hematoma, because all of those soft tissues of the birth canal that are supposed to kind of gradually accommodate, you know, this baby that's descending through, don't have time. It's just like the baby's flying through, so it's not tough. They can have injury from rapid passage, it can cause their head, it can cause nerve damage, descent through the birth canal. So we're always going to monitor. Everybody gets monitored for signs of injury, but particularly if they have risk factors. Let's pause for our break. All right, you can break until